Well, good morning, everyone, and welcome to this session of the Rapid Evaluation in Healthcare Conference. We're going to be talking about working together, which may sound like a bit of a truism. Of course, we all work together whenever we do almost anything, but there is a particular focus on how and the pros and cons of large-scale working together, which is something that happened in the Covid Oximetry at home evaluation, which is the subject matter within the overall topic for today's session. So to introduce myself, I'm John Sussex. I'm a senior researcher at RAND Europe, which is a not-for-profit policy research organisation based in Cambridge and Brussels, and we're part of the National Institute for Health Research funded BRACE Rapid Evaluation Centre, which is one of the many partners who were involved in evaluating the Covid Oximetry at home programme. And I'm delighted to introduce the three speakers we've got today who will be providing the meat for you. And first up will be Jonathan Benger. Jonathan is Chief Medical Officer for NHS Digital, and he's a consultant in emergency medicine and pre-hospital care at the Bristol Royal Infirmary, and also for the Great Western Air Ambulance. So a man of many parts, and among the many other things he did was to chair the frequent meetings of the steering group which drove the Covid Oximetry at home evaluation, but he'll be saying some more. Second up will be Karen Kirkham. Karen is partner and chief medical officer at Deloitte, and had a lot to do with the clinical and community of practice involvement in the evaluation we're going to talk about, and I'm sure she'll tell us about that. And then third along will be Professor Naomi Fulop. Naomi is the Professor of Healthcare Organisation and Management at University College London, and she was the principal investigator of a very large and broad evaluation team in this evaluation. So they'll be telling us what they thought to get us all going for a few minutes each, and then we'll have a discussion session as usual, and obviously that'll be much more interesting for everybody if we get some probing questions from you. There is, as you know, a Q&A function, so please use that to put in your questions to the panel, and then we'll have, we hope, a very interesting and I hope informative discussion at the end of the initial presentations. So Jonathan, if you're ready to go, over to you.
Thank you, John, and thank you for the introduction. Good morning, everybody. As you heard, my name is Jonathan Benger, and I'm the Chief Medical Officer at NHS Digital, and I had the pleasure of chairing the evaluation workstream in the Covid Oximetry at Home programme. For reference, I'm also Professor of Emergency Care at the University of the West of England and an NIHR Senior Investigator, so I do have a good understanding of research methodology, which I think was very helpful in this particular case. So to give you some of the background of how we got to where we got to, just to take you back to March 2020 and the first wave of the coronavirus pandemic, and I think it's easy to forget now how challenging that was and how little we knew at the time. My team in digital and data were working with an academic partner of the University of Cambridge on ethnicity and outcome from coronavirus and some of the very earliest data when concerns were raised around that. And the team I was working with said, do you know what, there's an association between the timing of hospital admission and outcome for coronavirus. And that was an incidental finding, but we went back and did some further research in May 2020 and confirmed that there was an association between admission and mortality. And for every day that you delayed between being diagnosed with coronavirus and being admitted to hospital, you increased your mortality by 1%, which at the time was a very novel finding, and led us to conclude that we should be identifying patients at risk and trying to admit them at an early stage through pulse oximetry. And at the same time, our clinicians, perhaps in May 2020, were saying there's a real problem with patients presenting late with silent hypoxia, very low oxygen levels, and they're suffering as a result. And so that led us to put forward a formal proposal to the National Incident Response Board, NHS England, to introduce Covid Oximetry at home. And that was approved in 3 pilot sites, which was London, Slough and South Tees. And so we commenced an initial pilot with an associated evaluation, and NHS England and the Chief Executive at the time, Simon Stevens, were very committed to evaluation alongside implementation. And I was very pleased by that, because I'm a huge believer in ensuring that we provide effective evaluation alongside service development. and had previous experience working with NHS England and the ambulance response programme, where we worked with Hra in Sheffield to ensure a very strong academic focus, and in fact had completed research on 13,999 calls to inform that particular change. So the evaluation was, I think, a really important part of that, but it's also important to understand that there were, at the same time, other systems around England already had or were introducing pulse oximetry for the same clinical reasons. And so there were a wide range of services starting to be introduced, and alongside those, a number of evaluations. Now, the first wave evaluation didn't show a conclusive evidence of a benefit, but it was significantly undermined by rapidly falling rates of coronavirus as we moved into the summer months. And so we didn't have enough patients really to be clear about the effects, but we did start to get some very important qualitative data. And then as the second wave commenced in September and October, we worked with NHS England and a wide range of partners to roll out a more comprehensive implementation of COVID oximetry at home to coincide with wave 2. And the principle was that there would be national guidance that would be implemented by CCGs locally, bearing in mind that many CCGs already had an effective service in place, and there was already quite a wide degree of variety in the services that were being provided. So as that rolled out, it provided the opportunity for a natural experiment. And in an ideal world, of course, a randomized controlled trial would have been helpful, but almost impossible to organize in the time frame, and potentially unethical to deny patients this particular monitoring technology, which was thought to be highly beneficial. And so alongside that full implementation, we recognized the need to continue with high quality evaluation. It also became apparent that there were a number of evaluations in progress. And one of the early challenges was to coordinate those evaluations and ensure that the various teams who were very committed to effective evaluation could work together in a synchronized way. And I think it's fair to say that there was some challenges in identifying teams and setting up an environment which allowed everybody to work together effectively. It's always a challenge when you're bringing together evaluation teams at short notice, where there's potential for overlap between the work that's being done, uncertainty about the commissioning mechanisms, and some potential for academic rivalry in that space. And so what was really impressive was the way that the 3 core academic partners that we identified came together, collaborated effectively with clinicians, with central policymakers, with digital and data expertise to create what was a really effective multimodal, one might describe it to some extent as a mixed methods approach, looking at the implementation of COVID oximetry at home in wave 2 from multiple perspectives across multiple teams and with multiple methodologies. And that close working was really critical to our success. Now, as you may be aware, we didn't demonstrate the hypothesized benefits from a quantitative perspective, but what we did do was demonstrate a huge range of really important findings to inform the future implementation of COVID oximetry at home and indeed similar services. And those similar services are now very much a part of policy for the NHS. As we roll out a wider program of NHS at home, and you may have seen in the planning guidance for NHS England released released just before Christmas for 2022-23, a commitment to create the equivalent of 5,000 additional beds through the expansion of virtual ward models. And so to realise that, it's absolutely essential that we do learn from the combined work that's been done. And also alongside that, ensure that evaluation is fully integrated into that work. So I think that's kind of how we got to where we got to, and what my kind of initial observation is that what this has demonstrated is how rapid evaluation teams can really work together with clinical policy and digital colleagues to rapidly evaluate emerging models of service delivery and inform the implementation of future approaches to transformed health and care. And I think that's a really valuable set of lessons for the future.
All right. So thanks, Jonathan. That's a great introduction. So yeah, Karen.
Thank you, John. I'm going to speak today, bearing in mind my role prior to the one that I am undertaking right now. So I'm going to speak to you in the sense that I was a national clinical advisor in primary care and system development through the last 3 to 4 years with the national team. And as part of that job, I was one of the GPs who was helping with the COVID response. So I'm a GP, continue to be a GP. And I worked alongside many others, clinicians, professionals, managers, and was privileged to work as part of the teams that helped to coordinate, I guess, this sea movement for change that was happening through particularly the early part of the pandemic. So I'm going to give you my role as a clinician, as a GP on the ground, but also working, I guess, between national policymakers, working with the research teams and trying to galvanise and disseminate and spread guidelines as they were developing best practice and so on. So my overwhelming sense through the last couple of years that this was a time for new ways of working. It wasn't just a time for new ways of working between clinicians, primary, secondary, community, ambulance teams, but it was a time of working between professionals across national, regional, local boundaries, working with CCGs and really trying to help galvanise and implement through a very rapidly changing environment. So as Jonathan has said, through that first wave, it's easy to forget that we were seeing catastrophic late presentations in hospital. In the community, we were seeing people sadly dying at home. And so there was this organic growth of using oximetry, which is a really simple means that was developing at pace across local clinical teams. For me as a clinician, it was really important to know we weren't doing any harm by doing this. So I think one of the clear evaluation principles was also to make sure that what we were doing, we wanted it to be obviously for positive benefit, but also to make sure that it wasn't harming patients was also really important. So as I said, the community teams were already starting to use the technology, a bit ad hoc, many different sorts of ways of doing this, but the conviction was that this was the right thing to do. And with help and support from the national team, from clinical specialists, we galvanised together, as Jonathan has said. One of the roles that I undertook was to set up a community of practice. Nothing special about this. It was just a meeting of minds, getting people together to share what they were doing. And that was where we picked those first 3 teams from the London, Slough and South Tees sites, where we knew that there were mature relationships, people already starting to galvanise around this way of working. And they helped us to just start those kind of early evaluation test beds. We did this through word of mouth, through social media. People joined, the community of practice grew. We provided very up-to-date information, and where local teams were devising new templates, new ways of working, things that would be labour saving were actually beneficial. We shared all of that in real time. Then we started to run national webinars, and those reached many thousands of people, disseminating that practice both in the UK but also beyond and around the world. As it happened, as further waves were stretching, we really saw the power of running those webinars in social media. And then of course, then in time there became a much more set group of people who then ran the information sharing through the learning networks, the academic health science networks, and patient safety collaboratives became increasingly involved, which is fantastic. So it became a way of rapidly disseminating updates. As I've said, local services were shared, but I think what it did was it brought the clinical teams alongside the research teams. So hopefully there was some benefit of that cross-working in real time, in touch with local teams, really starting, I think in my lifetime, the first time that I've seen anything like that develop so quickly, so positively, and working through the problems to try and understand how we could help the research and the evaluation take place as easily as possible. And data was a very big part of that. So NHSE, NHS Digital, all working alongside us to try and make sure that became a very agile, responsive network to the needs that we're developing. So just finally, I'm just going to reflect on local leadership being key. Courageous conversations were very prominent. We were very respectful in the way that we worked, and there was a real breaking of traditional boundaries. Not just, as I've said, between primary, secondary, community, ambulance, but also about that facilitative problem solving that I think became so powerful. And our legacy, I think, is going to be evident as we go forward. So we found new ways of working. We found different teams that we'd never worked with before. Organisational barriers were really crashed down. And as we've seen, there was an increased sharing of responsibility for the care of patients, which of course is paramount to what we want to do. And that will set up the way for new integrated models of care, as Jonathan has described. Already we've seen a powerful legacy of this way of working, patients also becoming increasingly responsible in a very personalised care model, but thinking about how this way of working can be directly applicable to many other long-term conditions as we emerge through the end of this next phase of the pandemic. And I think I'll stop there. Thank you, John.
Well, thank you. I should have said at the beginning, as an economist, I tend to think of things about having costs as well as benefits, and we'll come on to that, I'm sure, in a discussion. But no, that was really nice to hear about the joint working, how extensive and good it was. Naomi.
Thanks very much, and good morning, everybody. And thank you, Jonathan and Karen, for setting the scene and raising a number of issues. So my name's Naomi Fulop, and one of my hats is I'm co-director of one of the two NIHR rapid evaluation teams, RESET, and the other being BRACE. And the way I thought I'd start with the way our work programs are set, there's kind of two main ways. One is sort of top down. NIHR have discussions with national bodies to raise research issues that might be amenable for rapid evaluation. And the other is sort of bottom up, whereby clinicians and others come to us and ask us to evaluate their innovation. So this topic came to us top down from the funder in early summer 2020, and we put together a joint team from the two rapid evaluation teams from RESET and BRACE. Unfortunately, we had worked together before on other topics, and we worked initially with Karen's community of practice, as she's talked about, to develop a very rapid study. So we did what we call a scoping study, which we do prior to every rapid evaluation in 2 weeks, and those usually take months. So it's really to rapidly identify what are the key questions we're going to address, what are the methods. And the aim of that very rapid study was to look back at the first wave, at these, as Jonathan and Karen have described, this kind of ad hoc popping up of services all around the country using oximetry at home. And we, in that 2 months from July to September, we first of all did a rapid systematic review of the international literature, and we looked at 8 services which had been running in the first wave to kind of draw out the lessons for the coming second wave. And we worked very closely with Karen, as I said, and her group, and that's how we were very able to rapidly identify the 8 sites. As any researcher knows, that takes time, and to get in there and everything, that was all massively speeded up by working with Karen and with Martin Oderkim, who's the National Clinical Director for Deterioration and kind of the clinical lead for this program. So as I said, we did this 2-month rapid evaluation, and there's 2 publications in Lancet Eclim Med for those of you interested, and I know my colleague Holly Walton's on the call and she'll post links to those in the chat. So we drew out the lessons for the development of those services, which particularly around implementation. So things like any service should have what we call an analog mode, so a mode by telephone as well as a digital mode, which sounds obvious, but at the time it wasn't, and there were some people talking about going just digital only. And from our research, it was very important to have a non-digital and analog mode. And so our findings influenced the national rollout that Jonathan talked about of COVID oximetry at home, which is the kind of pre-hospital community-based service, and COVID virtual wards, which is the early discharge from hospital. And as Karen also talked about, there was this incredible dissemination of not just our findings, but informal learnings across the community of network, community practice, and then a national learning network. And this was all, from my perspective, really facilitated by remote working, as I'm sure lots of people watching this have found. So one of my favourite memories is Matt and Ada Kim emailed me on a Monday in October and said, because the rates were really going up in Liverpool City region, and he said, would you be available to present the findings on Thursday from 5 till 6? And I said, yeah, sure. And in sort of before times, that just wouldn't have been possible. And then, he said, oh, there'll probably be about 60 people on the call, and there were over 200. So we were able to present, and what was great, it wasn't just the research, we created a set of slides, it wasn't just the research team that presented those, so Karen used those slides and Matt did, so we got around the whole country in terms of dissemination. So in parallel, we were working up a phase 2 of our study to address the issues we hadn't been able to address in phase 1, so to look at effectiveness and cost effectiveness and patient experience. And we also discovered around that time that there was another team working in the area, as Jonathan alluded to, a team from Imperial. And a sort of honest reflection of that is that I think we went from competition to collaboration. The initial feeling, I think, on both sides was, ooh, who are these other team working in this area? This is our patch. I think that's honestly what the initial reaction was. But as Jonathan talked about and facilitated by him and others, we really came to work closely together with Imperial and then also the Health Foundation's IAU team over the course of a year on our evaluations. And there are kind of sort of 4 things I'd like to raise from all of that experience was, first of all, a lot of the issues that come out of this are common to non-rapid studies. So the kind of working with other evaluators in the field and also working with this huge range of stakeholders, again, Jonathan and Karen have talked about, but the complexity and intensity is something I haven't experienced before. And so there were kind of weekly meetings of all these various different groups. So the Friday meeting was the one that Jonathan chaired, and we had a Thursday meeting of the evaluators, and there were a number of other meetings that happened during the week. And so it was that kind of complexity and intensity, and obviously different stakeholders have different priorities. So we're working obviously with NHSE, with NHS Digital, with NHSX, and people, those are not homogeneous organisations, so people within those organisations have different priorities. So it's really important to understand what those are and work with people to build trust. The other issue that I wanted to raise was the importance of the independence of the evaluations. And that needed to keep being restated. And again, that's not an issue just for rapid evaluations and for all of the work we do, and I'm sure many people on the call, that's the case. But it was very important in this case in such a kind of high profile national rollout, and that's where NIHR's role was really important, and our funding from NIHR was very important to maintain that independence. And then there's also an issue about managing expectations of stakeholders you're working with, and that, and then a kind of, should I say, a disappointment with some of the findings not being quite what they might have wanted. So none of the evaluations were able to show an impact on outcomes in the way that the designers and service providers might have wanted, for reasons I'm happy to talk about later. And again, my colleague Holly will post links to our preprints from this study in the chat. But again, that's very important to manage that. And just finally, I'd like to say something about the team that worked on this. We actually had our kind of reflection session earlier this week, and these things only work when you have a team of, firstly, highly expert, skilled people, but in a way, more importantly, people who really committed, flexible, willing to throw themselves into things, change direction at short notice. So it's a kind of shout out to my team for all the work that they've done over this past year, 15 months. And I'll stop there. Thanks.
Well, thanks, Naomi. Thanks, everybody. So we've got a couple of questions coming through from the participants. I'm hoping there'll be a couple more before we finish. It seems to me that it's almost like you guys had organised this talk because you seamlessly have covered an awful lot of the ground without duplication. But I wondered if I could kick off a bit of discussion because which you've all touched on in different ways, which is there was a lot of different moving parts in this rapid evaluation, and that's on the researcher side, on the NHS organisation side, on the practitioner side, on the clinical side. So that didn't come without a cost, did it? So you mentioned that there were lots of meetings. So how far is this getting everybody involved and getting them involved frequently practical, does the panel think, for other evaluations in future? Happy for anyone to chip in at that point. Jonathan,
so I can start on that, John. Yeah, so I mean, I think so. The thing about coronavirus is it has accelerated everything. So things that used to take 2 years take 2 months and so forth. And to some extent, the same thing has occurred here. So rapid evaluation has become even more rapid. And so the compression of that means that the time commitment is substantial. Obviously, if you might have a certain number of meetings in a project and the duration is considerably compressed, then you end up having more meetings in order to achieve that. And with this project in particular, because of the very wide range of stakeholders and all the moving parts, there were a huge amount of meetings and an enormous amount of work, because as I say, in effect, you're just compressing it down into less time, which I think is entirely possible. But the question is it really sustainable? And so one of the challenges in general with the coronavirus pandemic has been that many people have worked extremely hard in health and care, here in research and evaluation. And if you say that's great, if you could just carry on doing that forever, we could all be a lot more productive. You might not get the results that you expect. So I think the challenge is to work out how to kind of learn the best lessons, but not necessarily kind of go too far down this line. There's a balance to be struck. We were probably too slow beforehand, but then during coronavirus there's a risk of going too fast. So we just need to work out what the right balance is, and inevitably, if you can, I mean, this is an incredibly fast evaluation, and the teams worked, really, 3 weekends into the evenings, in as many people have done in the coronavirus pandemic. People worked above and beyond to deliver, and that's not necessarily a long-term sustainable model.
So yeah, if I could come in there, and it's a really good question, John. I think I agree with a lot of what Jonathan said. I think particularly maybe in the beginning, till things got sort of streamlined, there was some duplication that wasn't efficient. But I think once sort of the systems got set up, there was some actually kind of meeting weekly is very efficient in some ways. Because it keeps everybody on board, so you don't have to have further meetings. And Jonathan stuck to an hour, and it's, it is amazing that we've all found what you can do in an hour with a good chair and kind of really cracking through. So I'd say there are things to learn from that for the future, but I think that the intensity. And I can see there's a question from Emma Hughes about Hra approval. And yes, we did, for our evaluation, get Hra approval. And that added to the meetings in that. And I remember this time last year when I think some of us were working full time on this study. in that not only did we have all these meetings with the stakeholders, but in getting Hra approval and then individual site approval, because we had 28 sites, took up a massive amount of time, and some of that was not very efficient and could be made more efficient, hint hint, for the future. So but I think the intensity can only is not sustainable in the long term.
Karen, yeah.
Yeah, Jen, just very briefly, really, from a clinical point of view, we repurposed a lot of meetings. We reprioritised because we had to, but that's happened all through the pandemic. And I think there's lots to learn about these new ways of working. Shorter focus meetings, with clear outcomes and deliverables at the end of it are definitely the way to go. I think we've learned a lot, and let's not lose those lessons either as we go forward, and life becomes hopefully a little bit calmer.
Yeah, we're getting a few questions which are basically more about robustness versus rapidity, and robustness in various dimensions, robustness of the evaluation. But I wonder if we can, in linking that through to the working together point, I mean, is there any way in which having lots of different people involved is a way of keeping the evaluation robust, even though you haven't got much time, or is it actually, is the robustness of the study completely independent of the number of people you've got involved?
Oh, that's a very good question, John. So I think there is a link in one sense, in the sense of, and I think we haven't mentioned this, which are important. So we had analysis workshops. I think we had 3 of them, which were kind of half-day workshops of the research teams plus all the stakeholders to discuss findings. We presented emerging findings to discuss them. So in terms of kind of face validity, those discussions were really important. But in terms of robustness of interpretation from stakeholders' view and also the evaluation teams. So I think that it can definitely add to the robustness. But I'd say that I think we need to challenge that issue that there's always a trade-off of robustness with rapidity. There doesn't have to be. Reset and Brace have found, I think, ways of working that are robust. So if you have a large research team working in parallel, you can do what other teams might take a couple of years to do much more quickly, but equally robustly. But that's not to say there aren't trade-offs with working rapidly.
And I was wondering if Jonathan or Karen, whether how robust it felt to you, or anything else you wanted to say on that issue.
Yeah, so I mean, I agree with what Naomi has said. I think there's no reason why it can't be robust if you're working in parallel. I mean, obviously there are constraints. There is a challenge. I think somebody's posted in the chat. Obviously, follow up. How long can you follow up patients for in a rapid evaluation? So that there are those constraints. I also think you do have to watch the in this particular situation. there were 2 challenges. Naomi's already alluded to the issue about academic independence, which needed some robust defence in order to maintain that principle. And I think the other is that sometimes there is a shortcutting, kind of cut corners sort of thing, where you say, well, it's a hurry, it's an emergency, so let's not bother to do this, let's not bother to do that. And so I think you have to be, that requires a degree of a rigorous senior academic oversight to be able to work out what can be done in parallel, what can be kind of abbreviated, what can be omitted, and what has to happen. And there are some things that absolutely obviously must happen. There's all the regulatory stuff, but I think there's an important question about the kind of methodological issues that needs to be defended by senior and kind of fierce academics who understand the need for very high quality research done by independent researchers in order for the findings to be credible. And so there are some important lessons from this, I think. I think all of our teams, and Naomi would be a perfect example of this, were extremely clear in their requirements for academic freedom and research of high quality, and that has to be maintained.
Yeah, I agree with you completely, Jonathan. And I think just to add, you know, I definitely think that my role and the role of many of the clinicians I work for was just to understand the requirements of that high quality academic research and be the facilitator to try and be able to enable that to happen in the best way that was possible. But, you know, just being mindful that we were being directed by very experienced, very high quality academic researchers. But it's that bit about working together and trying to make things happen in real time in a way that urgency made us work that way. And that was, you know, and so but I think we relied on, you know, the experts to tell us what they wanted.
Thanks. If I could just add, John, sure. I think an important lesson, it's really important to be clear about what you can and can't do with the research and what you can and can't say. Because we sometimes get pushed into, oh, could you, you know, from that, can you say such and such? And it's like, no, that's not possible. But we, you know, what we can say is this, that is really, that's really important. And the other issue about the robustness, because I can see there's a question about importance of qualitative evaluation, and yeah, to confirm that our evaluation was mixed methods, and that's another way of kind of increasing strengthening the robustness.
Yeah, and I just wanted to, Naomi, in your initial presentation, you talked a bit about dissemination, because I was wondering, and we've implied a lot about dissemination in what we've just been saying, or what you've just been saying, all of you, in the last few minutes, which is one of the features of working together, obviously, is that the people who are working together all get to see the emerging findings, and they understand the problems and the limitations, but they get to see the emerging findings. So I wondered if the panel had any views on whether this kind of extensive working together is a help or a hindrance to the dissemination of findings, because, you know, stuff gets out before it's finished, if I can put it that way crudely, but also stuff gets out when people need it. So what do people think about working together as a sort of dissemination practice?
Perhaps I'll kick off. I think it's really important to share those emerging formative findings, and that makes a study more rapid. I talked about those kind of analysis workshops, which were kind of sharing early findings, and they were within the group that was in that workshop. So the findings weren't at that point shared more widely, because all the teams had to go away and do further work, having discussed it there, and refinement and so on and so on. So personally, I think it's very important to share early on, but make clear, you know, that they are where they're emerging and where you can be more sure and less sure.
Yeah, I just add, I mean, we were at considerable pains to try and get the balance right between really working together as a team and sharing the findings, and as Naomi said, we held a number of very productive workshops, but also being clear about making sure that people understood the need for confidentiality, and not, as you said, there is a risk of leakage, and that has to be, we spent a lot of time emphasising both of those points, really. And I guess the other thing about rapidity is that it does reduce the opportunity for that. So there is less opportunity for people to kind of leak stuff out in unhelpful ways. But I mean, there is a balance to be struck, and unfortunately, I think on this occasion we had some great people working with us. We were able to discuss the findings in a very open way across a wide range of expertise, and nobody broke that confidence. I mean, it's becoming more and more complicated with modern dissemination, and, you know, lots of questions about dissemination these days. But I think what's really important, as Naomi has referred to, is not being sort of tempted down a line of saying more than the data actually provides support for. And that temptation in this kind of pressured environment can be very high, I think. because there is a lot of external pressure from stakeholders who obviously have a very vested interest in the outcomes of any evaluation.
And this is leading on to a question or two questions that are now in our inboxes, which is okay. So one of the major stakeholder groups, in fact, the most important one, we all agreed, is patients and public. So to what extent and how was it possible to, in this kind of rapid evaluation with lots of people involved, to get patient and public involvement in the evaluation?
Perhaps I'll kick off. So in terms of our evaluation, we're lucky in that both teams have an infrastructure for patient and public involvement, which we used for this study. So we went to the group at various points, kind of before, during, and after, if you see what I mean, to get their input as we were designing the study, and then during it, and then sharing findings after and the write-up and so on. I'm not saying that's perfect or that's enough. And in a sort of non-rapid study, one's able to do kind of more than that. And but I think we gave it a reasonable go. But it is one of the challenges of rapid evaluation, and so people's thoughts on that would be most welcome.
Yeah, so Naomi, I think from my perspective, again, just doing what we could to try and help to encourage that patient evaluation that in real time was really important. I think I'd also just, we talk about patient and users, which absolutely paramount importance, but also the engagement with staff delivering the service, I think was another line of kind of questioning that was also really important, how that was evaluated at the same time. So I think, again, just being in touch with local teams to try and facilitate the relationships to make sure that we were reaching as wide a number of patients as possible to get their views on what had happened and the way that they had engaged with the whole process of oximetry was absolutely critically important. We should and always should do more, better, earlier, more people, as diverse a group as possible, and stick to those guidelines all the time.
One of the things that's striking me, struck me when I was involved in my small way in the evaluation, was the point that you've all made, which is that the pressure of COVID, the pressure of the emergency, meant that, or certainly coincided with people being very willing to work together, and willing to work very quickly and very hard. So that's not going to, we hope, because we're not going to have any more pandemics, we hope, that situation is not going to occur very often, we hope, in future. But maybe there are occasions when there are things that need to be evaluated quickly and urgently for other reasons. I'm just wondering about what a good process might look like, and who decides what gets priority, because you can't prioritize everything. You can't prioritize, when there are 20 people turning up at meetings every week to get this evaluation done, you can't do that for everything. So the mechanism for deciding what was a priority here was slightly unclear to me, but I know basically I got told to do it and to do it quickly and to do it well. And so we did. So who decides which evaluations get priority? Any thoughts? Maybe to put in the too hard box, but yes, sorry, John.
It's a very extensive question, John. I guess it depends on the audience that you're. So, in here, I think the drive for evaluation was coming very strongly from NHS England, and actually from the Chief Executive for Simon Stevens, who's a very data-driven individual. And so he and I had worked together previously in this space, and he was very concerned about the risk of introducing services that weren't effective or cost effective. And obviously that's a really important consideration, because this is taxpayers' money, this is healthcare, there's a huge opportunity cost associated with this. And at the same time, the services were appearing and people were starting this work because the clinical voice was very strongly in favour. And so there's an additional imperative to say, okay, but let's at least do some evaluation. Let's understand this. Let's understand potentially where it works, how it works, why it works, does it work. So I think in this case that also aligned with the kind of commissioning priorities that the NIHR identified. I think it also very much aligned with the clinical priorities, because so the clinical upswell around this is something that needs doing was really very clear. Now, I mean, to turn that on its head, one could argue that prioritisation should be done by kind of the British public, patients and public, because ultimately we're generally spending their money on doing these evaluations. And that's, again, I think, an important role for patient and public partners is to understand what the evaluation priorities are. As Naomi's alluded to, you know, there is a sort of a top-down, bottom-up kind of potential here. Some of this just becomes serendipitous. And so in this case, there was no kind of, you know, we ended up somewhere very different, I think, from where we started from, and that worked fine on this occasion. I guess if you were confronted with a wide range of research priorities, then you would have to do some form of prioritization. That prioritization would have to take into account the views of public policymakers, clinicians, in order to try and prioritize the work. I mean, I guess you could accelerate existing prioritization processes that occur in research to try and do that if you felt that was the right thing to do. It's a fascinating question.
Just to add to that,
yes.
Sorry. I mean, I agree. I think the combination of top-down, bottom-up identification is really important, because if we only had top-down, if our evaluation programme was driven purely by NHS England and Department of Health, it would miss a lot of really important topics that have come to us and others working in the field. So, for example, one of our other studies that Reset's undertaken and completed recently is on pre-hospital triage for suspected stroke patients, which came to us from the clinicians implementing that. So that's about FaceTiming between paramedics and stroke specialists to enable patients to be taken to the right place. So that's just an example, but I think it's very important to have that pathway to pick up other, you know, really important innovations, and as Jonathan said, to include patients and the public in that as well.
We've got just literally a couple of minutes left, and I wonder whether I could again throw out a slightly, well, maybe slightly off-beam question, which can warrant maybe quick answers from the three of you. We know this was a relatively special case because of COVID, but to what extent is it useful? Would it be useful to do an evaluation of the evaluation? So in other words, would it be any use to steer any future practical decisions or resource allocations to know what worked and did, you know, formally to work out what did and didn't work well in this particular evaluation? So is an evaluation of the evaluation worth doing, or would it be actually not very useful?
It's good that we've entered the quick fire round, John. Must be getting near the end. I think we have already kind of drawn out some lessons learned, and this session helps to do that. I actually think we could do more. I think there are some important lessons, and on this occasion, I mean, you can get carried away with this, but an evaluation I think would be helpful.
Thanks. Yeah, Karen, got you?
Yeah, I mean, I think that looking back, it was really difficult to get some of the data in real time, and I think as we develop better data sets and develop that understanding, I definitely think that there may be more that we can do on this. So I don't think it would be a waste of time. I'd like to have a further look. That's what I'd like.
Yes, and on this meta question, yeah, agree. There are process issues about ways of working, but also, as Karen's highlighted, the issues around data, which are perennial in the NHS, and we really need to crack if we're going to be able to conduct robust, rapid and non-rapid evaluations.
Right, so definitely some issues. Okay, so well, thank you everyone. Thank you to our three speakers and for engaging with all of the questions, even the slightly odd ones that may not have seemed like they were specifically to do with working together, but they actually were, and they were all very interesting answers. So thank you. I'd like now to hand over to my Brace colleague Jo Ellis from the University of Birmingham Health Services Management Centre, who has the lovely task of kind of reflecting and trying to, I don't know, bring together what has happened in the conference today. So. Good luck to you, Jo, and over to you now, if you're ready. Yeah.
Thank you, John. Thanks ever so much. As John says, I perhaps have the rather now I see unenviable task of some concluding reflections, and I think it's unenviable because these sessions today have just been so rich and interesting. So I'm going to do my best, but forgive my flaws. I'm particularly going to focus on the two plenary sessions today. So the first of those sessions asked what is the evaluation research agenda for environmental sustainability in health and care? No small question in and of itself. And I think what we heard very early in that session, and Andy Haynes in particular, is emphasising is that environmental sustainability is fundamentally a health and a healthcare issue. You know, how we develop and how we deliver healthcare directly impacts on the environment and on climate. And conversely, as Martin Coyne emphasised, climate change has, and this is in his words, direct and immediate consequences for patients and for their health. I was really struck by David Pension's comment that given this, we need to see sustainability as a key dimension of healthcare quality alongside all of those other critical dimensions that we're already very much aware of, and that sustainability should be bound into how we understand, how we assess and how we improve quality in healthcare. The session was also really interesting in that it drew out, I think, some really important implications for evaluation and for those involved in evaluation. You know, we heard that there's a growing understanding of the many routes to net zero healthcare, and that evaluation is critical really for understanding what works and what doesn't, and if our strategies and our approaches are moving us towards those all-important climate change targets. Martin Coyne described evaluation of sustainability as a growth area, and lots of opportunities for evaluators. So assessing the environmental impact of new innovations, evaluating the potential of service redesign to contribute to sustainability, and informing sort of how that service design can be implemented and learning about that. And also talking about generating data to support scale up of effective approaches. So going beyond, in Martin Coyne's words, those pockets of good practice. We also, alongside opportunities, we also heard about challenges, fundamentally about the availability of data to assess the costs and impacts of innovations and new ways of working, including health impacts. We heard about the perennial issue for those involved in evaluation of how we deal with complexity, not only the complexity of changes themselves, but the environments and the settings into which they're introduced. And again, we heard about the lack of kind of metrics in key areas. But I was really struck here by David Pension's, I suppose, call to arms that we mustn't wait the 5 to 10 years for metrics to be developed. There is much that we can and indeed should be doing now. So that takes me on to this this final session, working together, and a really rich and interesting example. I think I was particularly struck, I wrote down as Jonathan said it, Jonathan's comment, that in the context of COVID-19, rapid evaluation has become even more rapid. And that for me is something of a theme that I think has run through this session. Jonathan Benjer talked a great deal about working together at many levels and many layers, and that included not just clinical, policy and digital colleagues, but of course the many evaluation teams who were operating in this space, and the coordination of all of those efforts to avoid potential overlap, to ensure complementarity, to avoid academic rivalry, although as Naomi Fuller describes, competition very much, I think, giving way to collaboration very quickly there. I was very struck by Karen Kirkham's sort of reflection on, and I think here, I think almost my overall reflection on this session is there's a very human story at the heart of this. You know, as an evaluator, I was very keen to think about methods and approaches, but actually it's what individuals and groups achieved, which seems to me to be such an accomplishment here. Karen talked about the role of communities of practice and the National Learning Network. So that very networked model of bringing people together, and remote working, of course, was actually a critical factor in that. But how to share not only the emergent practice of how to respond to COVID-19, but also then how to rapidly disseminate the evidence about how oximetry services were working, how they were being delivered, what they were achieving. And for me, what seemed critical there was about bringing clinical and evaluation teams together, because this wasn't just a dissemination task. This was, as Karen described, a problem-solving task. This was live problem-solving. It didn't just require data. Again, it required the human accomplishment of working through those data and what that might need. What that might mean, and the quote from Karen that we needed to be agile and responsive, I think, is really, you know, fundamental to all of that. Naomi, I think, really showed us that the sheer speed at which these studies were moving, and the challenges involved in that, but also the opportunities. As she said, you know, a scoping study for the oximetry evaluation was undertaken in less than 2 weeks. Well, typically that would take months, so radically compressing timescales down. And I think what was really interesting was the sense of working together, despite its challenges and its very multi-layered nature, really enabling rapidity. So as Naomi described, really enabling research sites to be identified and secured incredibly quickly. But what I really enjoyed about the conversation was how that evolved into the way in which working together actually added to the robustness as well. So it didn't just help to deliver a speedy study with expeditious findings, it actually helped to ensure rigour and robustness in the approach that was taken. Naomi emphasised several of the kind of challenges and dimensions, I think, of working together, which ring true, I think, for me as somebody involved in rapid evaluation as well. As she said, you know, working together is common to all evaluation work, but in a rapid evaluation, particularly in a super rapid evaluation of this kind, the complexity and intensity of that working together is only increased, and that raises challenges for both understanding but also managing people's expectations. And we heard again about, again, those personal skills about team adaptability and flexibility on all sides for everybody involved. And I suppose my final reflection then on this session is a sort of a kind of balancing between Karen Kirkham's sort of a suggestion that, you know, really urgency shows us what actually is possible, balanced against Jonathan Benger's comment that, you know, the working at pace, the sheer intensity, there are questions there about how sustainable that is. So this whole theme of sustainability, which has run through today, I think that's quite an important dimension, that working at pace and in such intensity was critical, but how long and how can that be sustained, and should that be sustained? I hope I've done some justice to those sessions in drawing them together. So I just want to say in sort of conclusion, for any of you who've missed any of the sessions today, they're all available on the conference platform. So please go back and watch any that you've missed this morning. Like all good evaluators, we have our own evaluation form, and we'd be really keen for you to complete that so that we can understand what's worked well today, have any suggestions for what could be improved, and that would be great to have your feedback. And finally, all importantly, I want to thank not only the fabulous speakers and the chairs and those I know who have been moderating the breakout session today. I also want to thank the conference organising team, those folk behind the scenes who are never seen, but whose work is absolutely critical to making a morning like this the success it has been. And finally, thank you to you as participants, both for coming along today, for the really interesting, I think, and thought-provoking questions that you've posed. They've helped to make the day what it is. I hope you've enjoyed the conference as much as I have, and just to say, I hope you enjoy the rest of your day. Thank you so much. Bye-bye.